Assalamu alaikum, the short clinical station day. First scenario, Mr. Salim Hassan, 45 years old, present with lower limb weakness. Please examine his lower limb. Here you
Hello, Mr. Salim. I'm Dr. Mansoor, one of exam candidate. I'm asked to examine your legs. Is it all right with you?
Okay,
If you feel any discomfort or pain, let me know. Okay.
okay.
I will see in the surrounding if any walking aid, wheelchair, glucose monitoring device.
There's walking aids.
Okay, thank you. I will inspect and palpate and percuss at the same time. Inspection for any wasting, deformity, fasciculation, atrophy changes.
Yes, there's wasting.
Okay, it is most prominently distal or proximal or both?
Distal.
Distal. Okay, any compensatory hypertrophy of the thigh?
No.
Okay, any biscavus?
No escapers.
Any visible fasciculation or impercussion fasciculation?
No.
Okay, any trophic changes, ulcers?
No.
Okay, I will examine for the tone
Okay. Where?
in the hip, circumduction
Okay.
maneuver, and rolling.
And where also?
And rolling method.
Okay. Okay, there is hypertonia.
Okay,
Where also?
okay, I will check for rigidity, also flexion and extension of the knee.
Okay.
The-
There is also hypertonia.
okay, I will check for the foot.
Okay. Hypertonia also.
Okay, thank you. I will go for the power. Can you push against my hand for the thigh?
Okay.
It's- Mhm. There is weakness.
Yes, there is weakness.
It's more flexor or extensor.
Yes, flexors weaker than extensor.
Okay, I will check for adduction and abduction of the thigh.
Okay, there is weakness.
Okay. I will see about the knee flexion and extension power,
Okay, there is weakness.
flexion or extension.
Yes, flexion is weaker than extension.
Okay, I will check for the legs. Can you push against my
Okay,
leg?
okay, there is weakness.
Okay. After that, I will do reflexes. I will start with plantar reflex. Is upward or downwards or equivocal?
Okay, there is upgoing plantar response.
Upgoing, thank you. I will do the reflexes,
Which reflex?
the knee and the ankle.
Okay, the knee is there is hyperreflexia in the knee.
And the ankle.
The ankle is absent.
Okay, thank you. I will do, however, colonus,
Okay, positive colonus.
patella, and adductor reflexes.
Patella.
Mhm.
Okay.
Okay, no. After that, I will go for coordination.
Okay, coordination is impaired. What is the instruction you will give to the patient?
Can you, with your foot, to the heel of the foot, above the knee, and go downward until the foot, the other foot?
Okay, it is impaired.
Okay, thank you.
Crossing of the leg. Okay.
Nothing because weakness. Okay. I will go for the sensation. Do you feel this? I will start with pinprick. Is this
So is it preserved pinprick?
preserved? Okay. I will dermatological distribution preserved. Okay. I will go for the touch.
Okay, touch also preserved.
Okay, I will go for the vibration.
Vibration lost until the knee.
Till the knee, okay. And joint position.
Joint position also lost.
1 minute left.
Okay. Can you walk? Can you stand up and walk?
Okay. During the walking, there is broad-based
Broad-based gait.
gait.
Mhm.
Okay.
Okay, thank you. You can lie down.
Okay.
Okay,
Finished.
finished. Thank you.
Still you
Okay.
have 30 seconds. Any other
Okay,
examination you want to do?
I can do pronator test and the coordination of the upper limbs.
No need, just examine lower limbs only.
Okay, thank you.
Okay. Okay. So present your finding.
Mr. Salim, 45 years old, coming with difficulty, weakness in the lower limbs. On the surroundings, there is walking aids. On examination, there is weakness and wasting of the distal muscles. There is no fasciculation. There is hypertonia and hyperreflexia with loss of ankle reflexes and upgoing plantar reflex and sensory regarding sensation. There is dissociative sensory loss of posterior column with perceived pain and temperature sensation. So here is the case with the combined posterior column affection and pyramidal
Sorry.
pyramidal
So,
pyramidal weakness and posterior column affection.
Okay. Okay. So this is your conclusion. So what is your differential diagnosis?
Here in this case, maybe hereditary spastic paraplegia. Against that is posterior column involvement, maybe subacute combined degeneration affecting pyramidal and posterior column, but no peripheral neuropathy. Maybe MS involving both of them. I want to complete the examination with doing the upper limb coordination and eye examination to see if any cerebellar involvement, maybe Friedreich ataxia, but I didn't appreciate any sensory loss.
Okay. So how you will investigate this patient?
I will I will complete the examination and I will do apart from basic blood test, including complete blood count, liver function, and kidney function test. I will do hemoglobin A1C and lipid profile, and I will do brain scanning and spine scanning. I will do nerve conduction test and the EMG.
Okay. If when you see the patient, you notice pallor. So any investigation you would to add?
Yes, I want to add vitamin B12 in this case and folate.
Okay.
And
So
also
how you
lead measurement of lead in the blood of motor
Mm,
weakness.
mm. Okay, so pallor, when you see pallor, what you will suspect?
Subacute combined degeneration, vitamin B12 deficiency or folate deficiency, maybe lead poisoning causing
So
iron deficiency, anemia, and motor weakness.
how you will treat the patient with combined subacute combined degeneration of the core?
Here is multidisciplinary team, including neurologist, the hematologist, radiologist, physiotherapy, and occupational therapist in this case, and non-pharmacological patient education and counseling about his condition, rehabilitation, physiotherapy, and pharmacological treatment of the underlying cause. If subacute combined degeneration, I will substitute with vitamin B12.
Do you know how the dose will be?
Yes, the dose of vitamin B is 1000 milligram, 3 times weekly for 1 month. After that, once weekly until third month. After that, according to the level, if reached more than 400 picomole per liter, I will maintain that once monthly.
Okay, thank you.
Okay, if you have folic acid deficiency,
I will
Dr.
start
Ahmed.
with vitamin B12 first to substitute vitamin
Perfect.
B12 because we will be mask the symptoms of vitamin B deficiency and aggravate the condition.
It can exaggerate the condition of subacute combined degeneration if you correct the folic acid first, okay? The other thing, what's the route of vitamin B12 you will replace? How you can give? The
Here is subcutaneous or intramuscular hydroxycobalamin.
yeah, intramuscular, okay. Thank you, Dr. Ahmed. Now, Dr. Hani, you can comment, please.
Okay, I have a comment. Firstly, about the examination. When you examine the power in the lower limbs, you firstly ask the patient to raise his legs against gravity. Okay, if he can raise the legs, so his power is 3 plus or plus 3. Okay, so firstly, you need to ask the patient to raise his passively, to raise his actively. Sorry, to raise his legs. If he can raise, so you start to do pushing down and pushing up in the size. Okay. After that, the reflexes. It is best to start with the knee reflex, and after that the ankle reflex. After that the plantar or the meniscal sign. After that clonus. To not forget. And also you examine the gait, but you forget the Romberg test. Okay, Romberg test here positive. Okay. What mean this Romberg test is positive? There is sensory ataxia. Okay, because there is posterior cord affection or lesion. Okay, so when you how you will present this case, Dr. Ahmed, you will say, is this patient, okay, by examination of the patient, this patient has, by inspection, there is a walking aid beside him. There is wasting in distally, and the gait is broad-based with positive Romberg sign. And there is signs of upper motor neuron lesion in the form of weakness, pyramidal shape, hypertonia, hyperreflexia in the knee, and pyramidal shape of weakness. Okay, and there is also signs of lower motor neuron lesion in the form of absent ankle reflex. Also, you forgot also in examination to inspect for any scars below the legs. Okay, you need to check for any scars below. So there is upper motor neuron lesion and lower motor neuron lesion. Also, one of the signs of the lower motor neuron lesion is wasting. So the signs of lower motor neuron lesion here is absent ankle reflex and wasting. So plus regarding to coordination impaired and sensation, there is a posterior colon affection in the form of loss of vibration and position sensation. Okay, and there is sensory ataxia because the Romberg test is positive. So if we collect our data here, we will find there is upper motor neuron lesion, lower motor neuron lesion, and posterior colon affection and sensory ataxia. So we will put our differential according to this finding. Okay. Okay. What is the differential diagnosis here? Firstly, subacute combined degeneration of the cord. Okay. The second differential will be multiple sclerosis. After that, Friedreich's ataxia. After that, cervical myelopathy. After that, taboparesis or syphilis. Okay, taboparesis. Okay, Dr. Ahmed. This is about the differential diagnosis. About the investigation. So here, if you suspect this is a combined degeneration of the cord, so you will do the basic investigation, especially CBC. You will see macrocytic anemia. Okay, macrocytic anemia, and you will do blood film also to confirm vitamin B deficiency. You will do serum vitamin B12 level and serum folic acid or serum folate, and also you can do serum methyl malonic acid. And you will do investigation to confirm or to search for the underlying cause. If we ask it about the causes here, the causes of vitamin B12 deficiency, Dr. Ahmed,
we take
you
it
can
for the case of malabsorption or gastric problem, pernicious anemia.
Okay, pernicious anemia, malabsorption, like what? The celiac or Crohn's?
Celiac or inflammatory bowel disease.
Okay, and post-gastrectomy, you say it, and ileal resection. And
start always with the intake. Patient doesn't take.
Yeah, so when he vegan.
Yeah. Vegetarian.
Dietary
yes.
deficiency.
Vegetarian.
Okay. So
continue, Dr. Hani. I mentioned the low intake. So patient not taking the vitamin B12 as in vegetarian. The second cause will be pernicious anemia. So the absorption itself.
The first cause will be a pernicious anemia. After that, the patient is not taking vitamin B12. That means dietary deficiency, or he is taking the vitamin B but not absorbed, so malabsorption, or taking vitamin B but there's a problem, structural problem in the GIT, like post-gastrectomy or ileal resection. Okay, this is the most important for causes: pernicious anemia, dietary deficiency, post-gastrectomy or ileal resection, and malabsorption. Malabsorption like Crohn's or celiac.
And short bowel, yes.
Short bowel, yes. So, or drug-induced like nitrous oxide abuse, alcoholism, metformin, BBI, proton pump inhibitors, okay, can cause also vitamin B deficiency or affect the absorption of the vitamin B12. So when we will do investigation, we will target this to identify the cause. We will do anti-intrinsic factor antibodies and antiparietal cell antibodies to check for any the pernicious anemia. If we suspect there is malabsorption celiac or Crohn's, we can do endoscopy, GIT endoscopy. Okay. After that, about the investigation, we will do neuro diagnostic tests like MRI spine. Okay, and a nerve conduction status. So the investigation will be basic investigations to confirm, or specific investigation to confirm, investigation to identify the underlying cause, and a neurodiagnostic test like MRI and nerve conduction status. How we will treat? Treatment will be non-pharmacological. It is multidisciplinary team approach. Non-pharmacological, physiotherapy and rehabilitation, and treatment of anemia if present, occupational health, occupational therapy, counseling and education of the patient, psychological support. Okay. After that, if the also if we suspect the cause is problem in dietary intake, like vegetarian, as you said, we must stop the vegetarian diet. Okay. After that, the pharmacological treatment will be a treatment of the deficiency by replacement of vitamin B. As you said, hydroxycobalamin 1 milligram intramuscular, 1 milligram intramuscular on alternate days for 2 weeks, 1 to 2 weeks. Okay. Then 1 milligram intramuscular every 3 months for life. I will say it again. 1 milligram of hydroxycobalamin intramuscular on alternate days for 1 to 2 weeks. Then 1 milligram every 3 months for life. Okay. After that, treatment of the underlying cause. If the pernicious anemia, we will take vitamin B12 lifelong injections. If the cause is malabsorption, like celiac, we will do gluten-free diet. Dietary deficiency, as I said, strict vegan diet. And if it is drug-induced, we will stop medication. Okay, this is about the treatment, investigation, and the causes. Okay, I finished my comment.
Yes, don't forget to add dietitian to your team. Dietitian.
Yes, that's right.
They are important. Okay. Now we'll get the skills, judgment. What about this physical science? Did he do the all examination steps in organized, systematic way?
About the physical examination, I will give him satisfactory, but he forget to the Romberg test. But I will not reduce the grades for the Romberg test. He do the gate, okay, except the Romberg test he did not. But I will give him satisfactory in the physical examination. I will give him unsatisfactory in the physical science because he missed Romberg test. Okay. He missed to present in his presentation the clonus, positive clonus, and the gate also. He missed the gate in the presentation. He do the gate, but he missed to present it. Okay. So about the differential diagnosis.
Okay, so you will give him unsatisfactory or borderline or satisfactory? I didn't hear.
In
the physical science, identify the physical science. Oh.
I will give him unsatisfactory.
Unsatisfactory.
Yes.
Okay.
Differential diagnosis.
Yes.
Satisfactory because he put differential subacute. The diagnosis the differential. Okay. Clinical judgment. I will give him satisfactory. Maintaining patient welfare. I will give him satisfactory.
So you will just minus him and identify the science.
Yes.
Okay. For me, I think once he mentioned all the findings and he picked up all of them during the examination, at least borderline, sorry, unsatisfactory. If he reached diagnosis, really, it's difficult to get it. Some examiners are tough to say and to judge. It's okay. But for today's case, I think he picked up most of his findings. Anyway, it's not bad mark. He can get around 18 out of 20. Even if unsatisfactory, might be 17. Okay.
Okay.
Any question, Dr. Ahmed?
Well, thank you, Dr. Hani, for the key.
Okay. There is a question in the chat box. What is the correct way to start examining the tone of the lower limb, active or passive? Also, regarding sensory, shall we examine first sensory level or dermatome or both at the same time? Good question, Dr. Asila. So let's start for the first part of the question. Always start in the order of tone, power, reflex, coordination, sensation. Why? Because it's easy to memorize and easy to follow. Tone, power, reflex, coordination, sensation, the gait, and the rhombic tests. Okay, the sensation, of course, you have to do. If you have time, you can do the 4 sensation steps or examination. I mean superficial by doing the fine touch or the pain, and for the deep touch by doing the joint and vibration. Okay, so fine touch for the cotton and the pinprick, and the deep for joint and vibration. Then the gait and the vibration, the gait and the rhombic test. This is regarding the tone. Yeah, the active or passive, the tone will be examined by passive. Okay, you cannot do the active as tone, the active for the power. The active for the power, because you cannot ask the patient to stress or to strain. The tone will be there, either inactive or sorry, either will be hypo or hyper or normal tone. So it's not something to be voluntary or active. The active in the power. Please raise your leg, push my leg, my hand, raise your thigh, push my hands inside or outside according to the induction, the adduction or abduction. But the passive for the tone. So you will raise or you will move the shoulder in rotatory movement. You will flex the knee and tell him, be calm, relax, don't do any movement. And the ankle movement as rotatory movement, the same as the shoulder, as the pelvis. Okay, this is how to assess the tone. The other question regarding the sensory level, dermatome or both, or dermatome or sensory level. I prefer to start with the dermatome. Okay, because there is patient will be having dermatome affection without sensory level, like peroneal nerve injury or ulnar nerve injury in the hand, but the patient will not have sensory level. So if you couldn't pick up this, you might miss it. If you start to do the sensory level and you find there is sensory level, you will not do the dermatome, and the dermatome might be there also. Okay, so the best way to start with the dermatome. What the cases come in basis with dermatome distribution, the peroneal nerve injury, as I said. So you'll have foot drop. Okay, foot drop. Or ulnar nerve injury, you will have claw hand. The median also can come as the carpal tunnel syndrome. You will not have sensory level, but you will have dermatome distribution. So start with the dermatome. If you have the dermatome, okay, then move to the sensory level. Okay? Clear now, Dr. Asila? Any other questions? Okay, thank you, Dr. Asila. Now we will go to the next scenario. Mr. Adam, 30 years old, gentleman with a complaint of short of breath. Examine his chest. Now your turn, Dr. Ahmed. Ready? We'll start straight away.
Okay.
Here you go.
Okay. Hello there.
Hello, doctor.
I am Dr. Abdul Hafiz, one of the candidates to exam today. I'm talking to Mr. Adam.
Yes, doctor, I am.
Okay, Mr. Adam, I would like to examine you. And during my examination, if you feel any pain or discomfort, please let me know. Shall I stop? Okay.
Okay, doctor.
Okay, I will start from the side of the bed by inspection of the surrounding for any oxygen cylinder, any sputum bots, any inhalers or medications.
There is a Ipratropium inhaler.
Okay. Okay, then I will inspect the patient if he breathlessness, in breathlessness.
No, he's
Breathlessness.
comfortable.
Okay. Okay, and I will ask the patient to take a breath in and out and to give me a cough. Hello?
Hello. Yes, I have cough.
Yes, dry cough or wet?
Dry cough.
Okay. Okay, after that, I will start by examination of the hands. I am searching for any clubbing,
No clubbing.
interstaining.
There is tar staining in the fingernails.
Okay, any deformity in the hands?
No hand deformity.
Okay, after that, I will ask the patient to stretch his hands in front of him and look and feel any tremors. And after that, for checking of flapping tremors.
There is fine tremor in the fingers.
Okay. Okay, then I will check the palms of the hand also for any pulmonary erythema.
No pulmonary erythema.
Then I will check the pulse.
It is 87.
And the respiratory rate. Pulse and respiratory rate. Sorry?
16.
16, okay. Okay, after I will check the eyes. Any pallor in jaundice?
No pallor, tinge of jaundice.
Tinge of jaundice, okay. Then I will examine the mouth. Any central cyanosis, any poor dental hygiene or gum hypertrophy.
No central cyanosis, only plethora.
Oh, okay, plethora?
Plethora, yes.
Okay. Bluteric phase. Oh, okay. So I will check the jugular venous pulse.
Jugular venous not congested.
Okay, I will examine the trachea for any tracheal deviation and for the cricosternal distance and tracheal tag.
The trachea is located centrally with slight deviation to the right. Reduce cricosternal below than 3 fingers. And there is tracheal tag.
Okay. So I will examine the lymph nodes.
There is no cervical lymph nodes.
I will do chest inspection for any scars.
No scars, but the anteroposterior diameter is enlarged.
Okay. So after that, I will do chest expansion from the posterior. I will start by posterior. I will do chest expansion.
It's reduced.
Okay. And I will do percussion.
Resonant all over.
Okay, and auscultation.
There is a vesicular breathing with prolonged expiration. No additional sound.
Okay. And I will do focal resonance.
It's normal.
Okay. I will start examining the anterior chest. I will do the same inspection.
1 minute left.
Inspection.
No scars, no dilated veins.
Okay, after that, chest expansion,
reduced,
percussion,
resonant, note.
and auscultation.
The auscultation vesicular with reduced, with prolonged expiration.
Okay. I will do the vocal resonance.
It's normal.
Okay, I will lastly palpate the apex and parasternal heave and second pulmonary.
Apex not palpable, or you can palpate.
Okay. Any parasternal heave or palpable B2?
No parasternal heave, no palpable B2.
Okay.
Time is up. If you have 1 or 2 seconds extra, what you will do, Dr. Han? Something you didn't look or you didn't examine. Okay. Forget about it. Time is up. Examiner questions.
Please present your finding.
Okay, by examination of Mr. Adam, who was complaining of shortness of breath, the respiratory rate is 16 cycle per minute, and also he is lying in 45-degree comfortable. Okay. From general observation, there is a Respiratory inhaler beside him. Okay, and his cough is dry. Okay, and by examination of the hands, there is tar staining and fine tremors. And there is also tinge of jaundice and the pleurotic face. Okay. The percussion is resonant. Chest movement is decreased bilaterally. Auscultation, the circular breath sounds, and there's expiratory wheezes, prolonged expiratory wheezes. Okay. I can't appreciate any signs of pulmonary hypertension, heart failure.
Okay, what is your differential diagnosis?
My differential diagnosis of obstructive lung disease for maybe COPD, obstructive lung, chronic obstructive lung disease, or asthma.
And keeping his age and jaundice, any correlation?
Maybe it's cystic fibrosis. I suspect cystic fibrosis.
Okay, thank you. What is your investigation?
Firstly, apart from the basic blood investigation, okay, I will do chest X-ray and high-resolution CT chest and pulmonary function test.
What do you expect in CT?
I will expect in CT reticular shadowing, maybe a bullae or emphysematous bullae, or
where should the emphysematous bullae in this case?
Sorry?
Apical or in basal?
No, basal.
Okay.
Okay. I will do also serum alpha 1 antitrypsin for the and sweat test for any. I will do serum alpha 1 antitrypsin for searching for the antitrypsin deficiency, and also for cystic fibrosis, I will do a sweat test. I will do also any complication. I will do ABG, also ECG, echo.
What do you expect in lung function test?
obstructive pattern.
Mhm.
Okay.
If the case is alpha-1 antitrypsin deficiency, what will you see? What you know about the pattern of alpha-1 antitrypsin?
It is autosomal dominant. Okay. Autosomal dominant disease. No, autosomal recessive. Autosomal recessive inheritance.
How to manage?
By replacing of how to manage it is non-pharmacological and pharmacological. Non-pharmacological education and counseling with the patient, stop smoking, and vaccination, pulmonary rehabilitation, and regular follow-up in the respiratory clinic. A treatment of the underlying cause, and also if it is antitrypsin deficiency, I will give him replacement, and bronchodilators, short acting and long acting, or combined inhalers, and or maybe.
Is there any definitive treatment of this case?
We sometimes we can do surgical treatment by lobotomy or low volume reduction. I mean.
Okay, thank you, doctor.
Or bulectomy. Okay.
Okay, thank you, Dr. Hani. You have the examination was systemic.
Thank you, Dr. Hani. You can comment now, Dr. Ahmed, please.
Okay. The physical examination was systemic. So he has satisfactory. Identifying signs was satisfactory or borderline because he doesn't do augmented hepatojugular reflex, and also didn't search for the apex if that dextrocardia or overlapping with the emphysematous. At least ask the patient to turn to the lateral side and try to examine the apex again to be sure. In some cases, maybe not palpable also, but you should do the examination. So it is borderline because the hepatojugular and don't search for apex. And differential diagnosis was very good, satisfactory. Clinical judgment, I will give, you have catch the alpha-1 antitrypsin and keeping the age of the patient. But there was some mistake in CT pattern with this reticular formation. But reticular pattern is with interstitial lung disease, not with emphysema. So you see emphysematous, this pan-acinar emphysematous pattern. That's homogeneous emphysema. This is not lobulated the lung as usual, 3 on the right and 2 on the left. So that's called pan-acinar emphysema. Welfare is satisfactory.
So the case is alpha-1 antitrypsin deficiency, right?
Yes.
Yeah. Once you mention jaundice, you have to think about it. Dr. Hani give you cystic fibrosis, which is not the relevant one.
Yes.
Yeah. Could be there, but it will not show the COPD or obstructive lung disease. It might be there, but supposed to be the cystic fibrosis will be like restrictive pattern more than obstructive pattern, right?
Yes.
Okay. Once you mention, Dr. Hani, once you mention the obstructive pattern in the pulmonary function test, explain it immediately. The examiner expected you to say so. So don't wait for him to tell you what you mean by that. Okay? So you tell to him, I expect the obstructive pattern in the form of forced expiratory volume 1 divided by the total or forced vital capacity will be less than 70, for example. And for the restrictive, more than 80. By yourself. Don't wait for him to ask. Because this is one of the clinical judgment points in the all exam. And all candidates has the chest or the respiratory system examination station. They have been asked about this question. What are the findings of pulmonary test in this patient? Okay. The genetic counseling is very important to mention here. Genetic counseling and screening, possibly for the next generation, because it's autosomal dominant one.
Yes.
Yeah, and the patient, if we couldn't do this screening for his family or for him himself, if he's planned for pregnancy or if she planned for pregnancy or if he's planning to have baby, maybe the kids will have the disease. So we have to do screening for him or to do the selection for the next generation. It's very important. So they like the point of screening and genetic counseling rather than managing the patient right now. Okay. For me, yeah,
I
continue.
wanted to complete regarding the investigation. Wants to hear about it. There are two possibility. This alpha 1 antitrypsin is a protein, so you can do protein electrophoresis. And here, four possibility, four variant. BI is the protein, and the variant M or S or Z. M is the normal, S and Z combination is the carrier of disease, and Z is the most worst one. So again, protein electrophoresis, you have different variant of this protein alpha 1 antitrypsin, either M or S or Z. M is normal. S combination of S and Z is carrier. Purely Z is the deceased one. You wanted to replace him. In some cases, rare case, there will be maybe not detected this protein at all, and should do an addition genetic analysis of the genes. But at least you should know from protein electrophoresis, this PIZZ is the diseased one, and he need replacement of alpha 1 antitrypsin. And regarding the management, the definitive management and cure of this case, this patient is liver transplantation, because alpha 1 antitrypsin is sensitized in the liver and the disease in the liver, and the consequence is the lung. If you treat the liver, the factory, it is definitive treatment of sure before the complication, and it is in the stage emphysema. Liver.
What about lung transplant? Is it only liver?
Lung transplantation is the only indication for lung transplantation with COPD. Most patient for lung transplantation is fibrotic lung, interstitial lung disease. The only exception for COPD is alpha 1 antitrypsin.
Yeah.
But if you catch it, diagnose the case, because here every case under the age of 40 diagnosed with COPD is routinely screening for alpha 1 antitrypsin. So they catch the diagnosis early. Don't waiting until there is end stage COPD.
Yeah, perfect. Okay. Thank you, Dr. Ahmed, for this case. It's a new, as discussed in our session, the alpha 1 antitrypsin. So the combination will be emphysema or obstructive lung disease along with jaundice or hepatic manifestation. By the way, supposed to say hyper-resonant. So it will be hyper-resonant, not resonant only. The resonant for normal person. But for asthmatic and COPD patient, it will be hyperinflated. So it's hyper-resonant. Okay?
Yep.
The other important management plan, one of the steps, it's crucial to advise stop smoking. Even if the patient is not smoker, you have to tell the examiner that if the patient is smoker, he should or he must stop smoking. Okay, this is one of the management plan, stop smoking. Okay. Any other question? There is some comments in the chat box. I will try to read quickly. Dr. Sahar Gamal. Also, enzyme activity of alpha-1 antitrypsin can be measured, and it's correlated with the genotype, with ZZ having the lowest activity. This is what Dr. Ahmed mentioned. The management plan as well, injection of alpha-1 antitrypsin, definite treatment. Okay, but in case of having the liver and the acute form, still the patient might present with the manifestation. So the definite management, as Dr. Ahmed mentioned, the surgical option will be liver transplant. Dr. Sahal also added cystic fibrosis will come as bronchiectasis rather than emphysema. Correct, yes. We mentioned this even in the obstructive lung disease. By the way, Dr. Hani, you mentioned chronic obstructive lung disease. Okay, you meant by that COPD, right? But
Yes.
it's called COPD, chronic obstructive pulmonary disease, because you mentioned lung disease, not pulmonary. So either to say COPD, chronic obstructive pulmonary disease, better to say it as COPD, then chronic obstructive pulmonary disease in this way.
Okay.
Anyway, the examiner will understand that you mean that COPD, but it's a major and worldwide abbreviation. So every examiner will know that you mean the COPD. Okay. In summary, the respiratory system station, either mostly in most of centers, either, and we mentioned that before, either obstructive lung disease or interstitial lung disease, or scar and previous surgery. Okay, this is the most common station all over the respiratory. Be ready to have any of them. Not exclusive, but most of them. You might have different station, okay, like dextrocardia with bronchiectasis, cystic fibrosis, but the main term will be either obstructive lung disease as a features, and the presentation will be like this. I suggest this patient is having obstructive lung disease. Then he will ask you what differential of obstructive lung disease, for example, COPD, asthma, or overlap, COPD versus asthma. Or you can say also obstructive, sometimes bronchiectasis can come as obstructive lung disease. What other station or what other title will be? The restrictive lung disease in the form of either interstitial lung disease as primary or secondary, or idiopathic pulmonary fibrosis or bronchiectasis. This is the major, again, term. Or the third title will be for scars. VATS scar, lobectomy scar, pneumonectomy scar, okay? Or lung reduction. All of them will be under the term of VATS scar. Or the last, what I mentioned, the lobectomy can be as VATS. Pneumonectomy will be different, will be large scar. And the scar of clamshell, I didn't mention it, clamshell scar. So let's repeat them. As I recall, 4 scars in respiratory station. Either small scar or multiple scar for VATS, or larger scar for lobectomy, or larger scar for pneumonectomy, and the largest is clamshell scar for transplant. So you have the undercostal area or cage scar extended from the right to the left. In all scar scenario, you will not have more than this station or more than this title in this station. Okay? This is as a recap for respiratory station. Any question for any topic? Any point to be added? Any point I missed?
How to differentiate between the lobectomy and pneumonectomy? A clinical examination way.
Good question. Thank you. Lobectomy will be smaller scar. So it's called thoracotomy scar. thoracotomy scar, it will be like parallel to the chest wall, but it's smaller than the pneumonectomy. Pneumonectomy, it can be extended from the back forward to the front, maybe parallel also to the chest wall. So it's around the mid line from the back till the anterior line of the midline in the front. This is pneumonectomy scar. The lobectomy scar will be smaller, just 5 to 10 centimeter at the chest wall, at the lateral chest wall. Okay, this is by the scar itself. What about other examination in the physical science? The trachea itself. So I might have trachea shifted, mostly with the pneumonectomy. The trachea might be shifted. Why? Because they remove the whole lung. So the trachea mostly will be deviated toward the side of the scar, which is pneumonectomy scar. If you have lobectomy or smaller scar, trachea expected to be deviated only initially, post-operative, because of the same reason, no space or no lung there, so the trachea will be shifted. Later on, for the long term, the other lobe can do a compensation, and the trachea again will be centralized. So the two things to differentiate the scar size or the trachea central or deviated. This is the most important differential between both. Okay. Any other question, doctor? Clear now this point? Yes, you can see also, as Dr. Sahar said, dull in percussion. However, it's not mandatory. You will find the dullness, because even in the lobectomy, you might have the resonance, yes. However, the pneumectomy, as Dr. Sahar mentioned, you will have a dullness. Sometimes you put cement or a substance which can lead to this dullness. But you might have also
Sorry, Dr.
global.
Bassam.
Yes, Dr. Mahjoub, sorry. Continue.
Lobectomy scar is larger or pneumonectomy, doctor? I think normally lobectomy is larger, no?
No, yes, pneumonectomy is larger. I said pneumonectomy will be from the back till the
Lobectomy,
front.
doctor. Lobectomy is larger, I think.
No. Pneumonectomy, they remove the whole lung.
Yeah, but it is difficult to remove the part of the lung. So I think lobectomy is larger, doctor.
How do you remove the lung, whole lung with the small scar?
Yeah, I can understand that, but I think it's easier to remove the all lung than part of the lung.
No, Dr. Yasser,
I'm
what
not
I
sure. I'm not sure, doctor.
yeah,
I think
no,
so.
I am sure it's lobectomy, which we call it thoracotomy scar, smaller usually. The pneumonectomy will be extended scar from the back till the front. Okay, I'm sure about this
Okay, doctor.
information.
Thank you, doctor.
Yeah, thank you. Dr. Sahar also confirmed it. Pneumonectomy is a larger, more extensive surgery. Yes. Thank you, Dr. Sahar. Thank you, Dr. Yas, also for the comment. I like to ask if you have any debate or conflict, because usually this one will fix the information. Whenever you have debate about information and you argue with anyone, it will be more fixed to your mind. So it's okay to ask and to confirm it. Okay, any other questions? You try to search in the Google, Dr. Yasser, about the pneumotic scar. You will see
Yeah,
it.
I have
Yeah,
searched for
doctor, I'm talking. Thank you,
yeah,
doctor.
for
Yeah.
pneumonectomy. You have to have larger scar because before removal of the lung, you have to reach the hilus and ligate bronchial artery and bronchial vein, and that need large scar.
Perfect. This is another justification. So you have to be more wide in your incision to explore more the chest and to reach to the hilum to do what Dr. Ahmed mentioned, to ligate either the
Yeah, thank you,
bronchus
doctor. Thank you.
or the heart. Yeah, thank you. Most welcome, Dr. Yasser. Thank you, Dr. Ahmed. Any other question before ending the session? Okay, thank you. Clear for all.
Okay.
Thank you, Dr. Hani, Dr.
جزاك الله خير
Ahmed.
دكتور.
جزاكم
جزاك
الله
الله خير.
خير.
شكرا.
آمين أجمعين. Thank you all. Thank you Dr. Hani, Dr. Ahmed. Thank you Dr. Yasser, Dr. Sahar, and Dr. everyone in the session. I hope I didn't miss any of you. See you tomorrow inshallah with long clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you Dr. Sahar.